Welcome to the RadOnc Smart Review CNS Cancer Series.
Great to be here.
Today we're tackling, well, one of the really big shifts in modern radiation oncology. It's this evolution from routine whole brain radiation therapy, WBRT,
Right, for patients with limited brain metastases.
Exactly. Moving towards stereotactic radiosurgery, SRS, alone.
Yeah,
And it's not just like a small tweak. It feels like a revolution, really.
it absolutely is, driven by some very solid level 1 evidence.
And that's what we want to walk you through today, that evidence, that story.
Yeah, because for a long time, WBRT was just the standard, almost automatic for many cases.
Right.
But the evidence came out, and our whole approach, our understanding, it just dramatically changed.
So this session, it's really about arming you with that foundational knowledge. Why SRS alone is, well, often the preferred way now.
The patient-centered approach. Preserving that vital cognitive function, without hurting survival.
Okay, so before we jump into the big trials, the ones that really reshaped everything, let's just set the scene a bit, clinically.
Good idea.
Brain metastases, I mean, we're talking about a really significant challenge for patients, aren't we?
Oh, definitely. And for us treating them, too. What makes it so tough, from your perspective?
Well, they can have such a profound impact. Neurological function, quality of life.
Yeah.
It gets incredibly complex.
And they often show up late, right? Part of more widespread disease. It adds another layer of difficulty.
Yeah. And while lots of cancers can spread to the brain, we see certain ones more often, like breast cancer, melanoma. Those pop up a lot.
True.
What's also striking, and maybe a bit bittersweet, we're actually seeing more brain mets overall.
Yeah. It's a strange consequence, isn't it? Our systemic therapies are better. Patients live longer, which is fantastic news.
But that longer survival sometimes gives the cancer more time, more opportunity to spread to the brain.
Exactly. So managing that intracranial disease effectively, it's absolutely vital now, not just for survival length, but for, maintaining function, independence, well-being.
So given that complexity, what's our #1 tool for finding these mets, seeing how many there are? What's step 1 in the workup?
Oh, hands down, it's the brain MRI. It's just indispensable for the diagnosis, for seeing the number, the size of the lesions.
It guides everything after that.
Absolutely. It's a cornerstone. You need that good quality MRI.
And then once we see the mets, we need to know about the patient, right? Their overall well-being, their functional capacity. We use the KPS for that, the Karnofsky performance status. So
Yeah.
KPS of 90, for example, that tells us someone's pretty independent, functionally strong,
Yeah.
makes them a good candidate for maybe more focused therapies.
Yeah, performance status is huge. It really dictates a lot in our algorithms, helps us figure out what they can tolerate, what their quality of life might look like afterwards.
And just briefly on pathology, the specific pathology of the brain met itself isn't something we have deep detail on here, but the primary cancer's pathology.
Oh, that's still super relevant.
Right. Breast, melanoma, lung. That informs the systemic therapy choices, which can impact the brain disease too. And it gives us clues about how the tumor might behave.
Definitely. It helps predict the biology, helps tailor the whole strategy, radiation dose, sequencing with drugs, all of it.
Okay, let's get to the main event, the trials, the level 1 evidence that really sparked this SRS revolution.
Right, because WBRT was the standard for decades, almost reflexive.
But science builds, right? Our understanding evolves through these big clinical trials. And to help you kind of track these key studies.
You came up with a little something.
Yeah, a mnemonic. Think. RACE to cognition. RACE.
RACE, so that's R for RTOG, A for Aoyama, C for Chang, and E for.
Oh, well, Alliance technically N0574, but E works.
Exactly. RACE to cognition. It's a race to preserve brain function, and these trials really pave the way. And to make this really concrete, let's think about a typical patient scenario. You'll definitely see this.
Okay.
Imagine a, say, 55-year-old woman, history of breast cancer. She starts getting new headaches, gets a brain MRI. It shows 3 new metastases. The biggest is maybe 1.5 centimeters, her systemic disease, stable, KPS, a good 90.
Okay, pretty common picture.
Right. So the question is, 20 years ago, what would we have done?
WBRT? Almost certainly, without much debate.
Exactly. But today, what's our approach now? And that's where this evidence we're about to dig into is just critical.
Couldn't agree more. Okay, let's start our RAC mnemonic, RTOG 9508. Published back in, what, 2004?
That's the one.
This was really the first big study that showed SRS was a valuable player here. What was the exact question they were asking?
So 9508 looked at patients with 1 to 3 brain mets, and the question was pretty straightforward. If you're already giving WBRT, does adding an SRS boost actually improve survival?
So WRT alone versus WBRT plus the SRS boost.
Precisely. They randomized patients that way. Now, technically, the trial was negative for overall survival for the whole group, but there was a really key subgroup analysis. For patients with just a single metastasis, adding that SRS boost did show a significant survival benefit.
Really? How much?
Median overall survival went from just under 5 months, about 4.9, up to 6.5 months. And maybe just as importantly, the boost significantly improved local control for all patients, regardless of the number of mets.
Okay, so RTOG 9508, it didn't maybe hit the primary endpoint overall, but it definitely put SRS on the map as a powerful tool, especially for local control.
Absolutely. It established its value.
And it set the stage perfectly for the next logical question, the A in RACE. If SRS works so well as a boost.
Do we even need the WBRT part?
Exactly. Could we maybe just omit it? Was it necessary?
And that brings us to JRSG 99-1, the IAMA trial, published 2006.
This one felt pretty groundbreaking at the time, didn't it? First, to really challenge WBRT's necessity.
It really was. How did they set it up?
They took 132 patients, again, similar group, 1 to 4 metastases this time, and randomized them straight up, SRS alone.
Versus SRS plus immediate WBRT. Very direct comparison.
And the results. What did they find?
Well, this was the surprise. No difference in overall survival. About 8 months median OS in both arms.
Wow. Okay, so survival was the same whether you added a whole brain or not.
Right. But, and this is a big but, there was a clear trade-off. Adding WBRT significantly improved intracranial control.
Meaning fewer new tumors popping up elsewhere in the brain.
Exactly. The 1-year rate of brain tumor recurrence. It was way higher with SRS alone, something like 76%, compared to about 47% if you added the WBRT.
Okay, so IAMA's key takeaway. Omitting WBRT didn't seem to hurt overall survival.
Right.
But you paid a price in terms of higher risk of cancer coming back elsewhere in the brain. Intracranial recurrence.
Precisely. And that left the field in, well, genuine equipoise, real uncertainty.
Yeah, a dilemma. What do you prioritize? Better brain control with WBRT or avoiding potential WBRT side effects if survival's the same?
It was a tough spot. We didn't have a clear answer.
But that equipoise, that uncertainty, it got shattered pretty definitively by the C and RACE mnemonic.
Yes, the Chang trial from MD Anderson.
Yeah.
Published 2009.
Right. So Chang et al. Also randomized patients, 1 to 3 mets, SRS alone versus SRS plus WBRT. But the game changer here was the primary endpoint.
Correct. It wasn't survival. It wasn't even local control, primarily.
It was neurocognitive function, specifically using the Hopkins Verbal Learning Test, the HVLT.
And what they found, well, it stopped the trial early.
Stopped early. Wow.
The Data Safety Monitoring Committee stepped in because there was such a dramatic, statistically significant harm to cognitive function in the WBRT arm.
Harm? How bad?
At just 4 months post-treatment, the rate of memory decline. It was more than double in the WBRT arm. Over 50%, I think 52%, showed decline compared to about 24% in the SRS alone arm.
Wow. 52 versus 24% at 4 months? That's huge.
It was an absolute bombshell, just shook the field.
This was the first really high-level, clear evidence showing WBRT causes significant cognitive damage. We sometimes use that analogy, right?
The garden analogy.
Yeah, like you've got a few weeds in a beautiful garden. You can meticulously pull them out. That's like SRS.
You could just pave the whole garden over with concrete. Gets rid of the weeds, sure.
But you lose all the flowers, too. WBRT was kind of like that concrete impacting cognition so broadly.
That really hits the nail on the head. Before Chang, these cognitive effects, they were often kind of hand-waved away or blamed on the cancer or medications. This trial made it undeniable. And it wasn't just data, it was like an ethical challenge. It forced us to ask, what does success really mean if we save someone but significantly diminish their quality of life, their ability to think clearly?
Yeah, a real turning point. Moving beyond just tumor control to thinking about the whole patient, the person.
Okay, so Ayama raised a question. Chang provided the stark warning about cognition, which perfectly sets up the next big one.
The E in RACE Alliance, N05 0574, published 2016. The big, definitive, multi-center North American trial.
This is meant to be the final word, really. Very robust study.
Right.
213 patients, again, 1 to 3 brain mets, randomized SRS alone versus SRS plus WBRT.
And crucially, like Chang, primary endpoint was cognitive deterioration.
Yep, mirroring that focus.
And the results.
Right.
Did they confirm Chang?
Oh, absolutely. And then some. Adding WBRT led to significantly worse cognitive deterioration at just 3 months this time.
3 months, wow.
Yeah, the failure rate, meaning cognitive decline, was something like 92% in the WBRT arm versus 64% for SRS alone. Huge difference.
92% cognitive failure rate at 3 months with WBRT added.
And not only that, quality of life also significantly better with SRS alone.
Okay, better cognition, better QLL.
Yeah.
What about survival? Did adding WBRT help people live longer in this big trial?
Nope. No difference in overall survival at all.
So that's it then. Alliance N0574 basically cemented it.
It really did. It showed you could preserve cognitive function, maintain quality of life, and have the same overall survival by using SRS alone for these patients.
It truly solidified SRS alone as the standard of care. For 1 to 3 brain mets, good performance status, changed practice everywhere.
And then just to add one more important layer, there was a meta-analysis by Sagal and colleagues, pooling data from these key trials.
Right. Meta-analyses can give us even more power, especially looking at subgroups. What did Sagal find?
Something really crucial, particularly about age. For younger patients, specifically those under 50, adding WBRT wasn't just neutral or only affecting cognition. It was actually associated with a detriment in overall survival.
Wait, adding whole brain hurt survival in patients under 50.
That's what the pooled data suggested. A statistically significant decrease in overall survival for that younger group if they got WBRT added to SRS.
Wow. Okay, that's incredibly important.
It provides the strongest possible rationale for SRS alone in those younger, fitter patients. It's not just about cognition. It might actually impact their survival beneficially.
Okay. We've just gone through a whirlwind tour of some really practice-changing trials. RACE to cognition.
RTOG, Ayama, Chang, Lyons.
Right. So now let's try and boil this down. To help everyone remember the key messages for clinic, for boards, let's shift to some clinical pearls.
Sounds good. Pearl number 1, RTOG 9508. Remember, this one established the benefit of adding an SRS boost to WBRT, especially for improving local control. Showed SRS was a valuable tool.
Pearl number 2, the Ayama trial, JROSG 99-1. This was the first to show SRS alone had similar overall survival to SRS plus WBRT. Big finding. But the trade-off was worse intracranial control. Left us in equipoise.
Pearl 3, MD Anderson's Chang trial, the wake-up call. Stopped early. Why? Significantly worse cognitive decline, specifically memory, at 4 months in the arm that got WBRT added. Remember those numbers, 52% versus 24% decline.
Pearl 4, the definitive alliance N0574 trial. This confirmed the cognitive harm, 92% versus 64% deterioration at 3 months with added WBRT. And critically, absolutely no overall survival benefit for adding WBRT in patients with 1 to 3 mets. Better QOL with SRS alone, too.
And the final overarching pearl, number 5. You put all this high-level evidence together. SRS alone is now the clear standard of care for patients with a limited number of brain metastases, usually 1 to 3 or 4, and good performance status.
Okay, those are great pearls. So how does this evidence actually guide us in clinical decision-making when that patient is sitting in front of you?
Well, this evidence pretty much dictates the treatment algorithm now for limited brain mets again, usually up to 4, but the key trials focused on 1 to 3. The strong preference, the standard, is SRS alone if they meet the criteria.
And those criteria are key, right?
Right.
Patient selection is paramount.
Absolutely. Good performance status, like KPS 70 or higher, often 90, and the number of metastases falling within that limited range.
So we're consciously making that trade-off now. We understand it better.
Exactly. We know WBRT can offer better intracranial control, fewer new mets popping up later, but we also know that comes at a significant cost. Cognitive decline, worse quality of life.
And for most patients, crucially, no improvement in how long they live overall.
Right. And remember that Sagal finding for younger patients under 50, WBRT might actually be detrimental to survival. So the argument for SRS alone is incredibly strong in that group.
Okay, let's talk treatment techniques just briefly. In this context, we're mainly comparing whole brain radiation therapy, WBRT, and stereotactic radiosurgery, SRS.
Those are the two main players in these trials, yeah.
Can you just quickly contrast how they're used based on this evidence?
Sure. So historically, WBRT was the broad approach, right?
Mm-hmm.
Treat the whole brain, catch known mets, maybe catch microscopic stuff we couldn't see. Comprehensive, but broad.
And SRS?
SRS is the opposite. It's highly focused, extremely high dose of radiation delivered just to the specific visible lesions, very precise, aiming to spare the surrounding healthy brain.
And the shift we've been discussing.
Is that SRS went from being just an add-on, a boost after whole brain, to becoming the primary standalone treatment for many patients with limited mets. It's the default for suitable candidates now, thanks to these trials.
Perfect. Okay, time to put this knowledge under pressure. Ready for a quick board blitz?
Let's do it. Fire away.
All right. Question 1. The landmark MD Anderson trial by Chang, comparing SRS alone to SRS plus WBRT, was stopped early. What was the primary reason for early termination? Was it A, unacceptably high rates of radiation necrosis in the SRS alone arm? B, significantly worse overall survival in the WBRT arm? C, a significantly higher rate of cognitive decline in the WBRT arm? Or D, a lack of patient accrual?
Okay, the reason Chang was stopped early, it has to be C. The significantly higher rate of cognitive decline in the WBRT arm. That was the dramatic finding that halted the trial due to patient harm.
Correct. It was that clear detriment to cognitive function. Okay, question 2. Which statement best synthesizes the primary findings of the Alliance N0574 trial? A, adding WBRT to SRS improves overall survival, but worsens cognitive function. B, adding WBRT to SRS improves intracranial control, but worsens cognitive function with no overall survival benefit. C, adding WBRT to SRS has no impact on intracranial control or overall survival, but worsens cognitive function. Or D, adding WBRT to SRS improves both overall survival and intracranial control. Okay, think about Alliance. It confirmed the cognitive decline, showed better intracranial control with WBRT, but crucially, no OS benefit. Yeah, it sounds like. B, adding WBRT improves intracranial control, but worsens cognitive function with no overall survival benefit. It's exactly right. Answer B captures that central trade-off perfectly. Okay, last one. Question 3. A 45-year-old patient with melanoma and 2 small brain metastases is discussing options, SRS alone versus SRS plus WBRT. Based specifically on the meta-analysis by Gall, what can you tell her about the effect of WBRT on survival in her age group, under 50? A, adding WBRT is likely to improve her survival. B, adding WBRT is likely to be detrimental to her survival. C, adding WBRT has no impact on survival for her age group. Or D, the effect of WBRT on survival is unknown for patients under 50.
The Sagal meta-analysis focusing on the under 50 group. That analysis specifically found WBRT was associated with worse survival in younger patients. So the answer is B, adding WBRT is likely to be detrimental to her survival.
Perfect. That's a critical point for counseling younger patients. So wrapping up that section, this whole discussion just highlights how that equipoise we felt after Ayama.
Yeah, the uncertainty.
It was just so decisively resolved by Chang and then Alliance. It really feels like a monumental advance, doesn't it? Shifting from automatic WBRT to SRS alone, it's a huge win for patients' quality of life.
It absolutely is. A profound improvement. Better cognition, better quality of life without sacrificing survival for the right patients. Of course, the work isn't done.
You're right.
There are still challenges, nuances, like how best to treat the cavity after surgery for a brain met. That's a whole other topic.
And one we'll definitely tackle in a future session.
Okay.
So let's try to summarize today's journey through the SRS revolution.
Okay. We traced this really interesting history. Started with RTOG 9508. What did that show?
Showed the benefit of an SRS boost added to WBRT. Established SRS as a strong local therapy.
Then came Aoyama JROSG 99-1. First to ask if we could omit WBRT, found similar survival.
But worse intracranial control. Leading to that initial uncertainty, the equipoise.
Which was then shattered by Chang. The MD Anderson trial. The bombshell. WBRT causes significant cognitive harm. Stopped early because of it.
And finally, Alliance N0574. The big, definitive North American trial. It cemented SRS alone as the standard for 1 to 3 mets. Proved unequivocally that adding WBRT hurts cognitive function and quality of life.
With absolutely no overall survival benefit.
So the take-home message, the strong recommendation.
Clear and evidence-based. SRS alone for patients with a limited number of brain metastases, good performance status, and especially compelling for those patients under 50.
This whole story, this evolution, it really underscores a bigger shift happening in oncology, I think. This deliberate focus on patient-centered outcomes.
Yeah, not just survival numbers.
Right. Quality of life, cognitive function, what the patient actually experiences. And it kind of makes you think, doesn't it? A final thought, maybe? How can we apply the same evidence-based balancing act, efficacy versus quality of life, to other areas in our field? Where else should we be asking these critical questions?
That's a great point to ponder. Okay, time to wrap up. Complete practice oral boards at radononyxsmartlearn.com. That's radononyxsmartlearn.com. And subscribe to Rad Onyx Smart Review for our next episode. Thanks for tuning in.